Everybody, and welcome to this pre-recorded session, which we will look at the IMCA role within serious medical treatment decisions. So this session is really aimed at IMCAs, but also any advocates that are working with people who lack capacity who might be affected by a serious medical treatment decision. Sometimes you'll hear the acronym SMT, and that's all it means: serious medical treatment. In this session, we're going to really cover three things. One, we're going to absolutely nail what we mean by serious medical treatment. Then we're going to spend a bit of time thinking about the IMCA role when somebody is having a decision made about serious medical treatment. And then we'll finish this session thinking about report writing and how to structure your report. Does that sound amazing? So yes, it sounds amazing. So first things first, just wanted to refresh your memory that there is a statutory duty to arrange an advocate and instruct an advocate for an eligible person. And an eligible person in this setting, in this situation, is that the person lacks capacity to make the decision about serious medical treatment, and there are no family or friends who it's appropriate to consult with. So if your partner hits that criteria, then they have to have an IMCA constructed. And the role of the IMCA within this decision making process is really to make sure that the decision takes account of the person, and you're there to represent the person's wishes or likely wishes, and you're there to ask questions, explore options, and a good standard approach, the sensible benchmark for this, if you're not sure about what questions to ask, is if this was your loved one, if this person, if your partner was your mom or your child or your cousin, your sister, what type of questions would you want to know? Would you want to have a second opinion if things were a bit uncertain? Would you want to know about the alternatives? Would you want to know about the side effects or the long-term consequences? Of course you would. These are the types of questions that you're going to be asking. So you're not coming at it from a kind of a medical professional perspective. You're definitely coming from a very natural human. What type of questions would I realistically and reasonably be wanting to ask if this person was my loved one? And they're the ones you're going to be asking. So serious medical treatment is defined in regulations, by which we mean the Mental Capacity Act and the IMCA Code of Practice. And serious medical treatment is defined where the decision is about providing, withdrawing, or withholding treatment, where one of these three things will happen or are likely to happen. So the first one is that there's one single treatment being considered, and there's a fine balance between the benefits and the burdens of that single treatment. So let's imagine that the treatment being proposed is some dentist work, and the proposed treatment would be a removal of a tooth. Then the single treatment is the removal of the tooth. If there's a fine balance between the benefits and the burdens of having that intervention, then that makes it serious medical treatment. The second one is if there are a choice of treatments, and the choice of treatments might be finely balanced. So to give you an example, that could be, let's say the person has a diagnosis of cancer, and there may be an option to treat with chemotherapy, or there might be an option to do surgery, and there might be a third option of a combination of both. And the kind of the choice between which one of those three is finely balanced. So that would make it serious medical treatment. Then there's a third kind of category, which is simply described as if the decision being proposed is likely to involve serious consequences, well, then that makes it serious medical treatment. But that's quite a broad statement, isn't it? Serious consequences. What might be serious for me might not be serious for you. So it's thinking about what's the likely impact of this proposed treatment for this person. And a great example of this is something like the COVID vaccination or a flu jab. So if I can tolerate needles and I have consented, and when I go to the surgery for my annual flu jab, I offer my arm, then that might be fairly straightforward. If, however, I have a phobia of needles or I get very, very distressed, well, then all of a sudden that decision becomes quite serious because it might involve being restrained. Well, that's a serious consequence. Or it might involve me becoming very, very upset and distressed. So even though it's a simple flu jab or a simple COVID vaccination, it might be serious medical treatment. But they're the types of things to be thinking of. There's no automatic um, kind of treatment that goes on the list of serious medical treatment. This is the guidance, and these are the kind of the three examples to be thinking of. The guidance does give us some more content around serious consequences. So if ever you come across in your advocacy work treatment options that might cause serious or prolonged pain, or might have cause distress to that individual or have side effects, or anything that has major consequences. So this might be things that are non-reversible. So a permanent stoma bag or a permanent catheter, those types of things, that's going to have major consequences. And of course, if anything has a serious impact on the person's future life choices, then that's likely to make it a serious medical treatment. So a really broad range of medical decisions will fall under SMT. And the Mental Capacity Act does give some examples, but these are quite obvious because I think because these are very, very invasive and very serious, non-reversible. It does talk about ECT, and I just wanted to have highlighted like check, because most people who receive ECT will be receiving that under the Mental Health Act. If the ECT is authorised under the Mental Health Act, it will not come under the Mental Capacity Act because the framework is the Mental Health Act, and there are safeguards there to protect the person's rights and choices and make sure that that's the right process forward and right treatment. It is possible for ECT to be authorised under the Mental Capacity Act, in which case it's likely to be classed as SMT. In 15 years of being involved in advocacy, I can think of one person I'm aware of that's had ECT under the Mental Capacity Act. It's very, very uncommon. So the first thing to check is under which legal framework is the ECT being authorised. And if it's Mental Health Act, then it will go to the Mental Health Act. Okay, the two exclusions to IMCA, so this is where the treatment being proposed or administered, it is classed as serious medical treatment. But the exclusions that mean that you don't need to appoint an IMCA would be an obvious one where it's urgent. So, if the person's in A&E or emergency care has to be administered to save that person's life, then they are not going to stop that process in order to consult an IMCA. Of course not. So that there's just a very sensible exclusion. And then there's the kind of the legality of if the treatment is being authorised under the Mental Health Act, then you wouldn't have an IMCA. But you would, of course, have an IMHA. So the person would still be entitled to advocacy. So you might want to pause just to ask any questions or have a think about what constitutes serious medical treatment. So yeah, if you want to kind of press pause, otherwise we'll go straight into the IMCA role. Okay, so let's think about the IMCA role within serious medical treatment decisions. And of course, the IMCA role, like all types of advocacy, is about choice, it's about voice, and it's about rights. So we are going to start with self-advocacy, and particularly in your work with people who lack capacity to make decisions, the need to really think carefully at the beginning of your involvement and ask that really sensible question: how and who is supporting my partner to make their own decisions? How is the person being supported to make choices? What additional resources, what augmented communication is needed here? Because what we want to do as much as we can is to help the person make the choice and certainly express a view on what it is that they want to happen. where you can't get that directly. And in serious medical treatment decisions, that can happen frequently because the person might be very, very unwell. Yeah, I've visited people in hospital and they're unconscious. It's not possible, or they are heavily medicated and sedated because of pain. It's not possible to have that conversation and spend that time. But the starting point is always to ask that question and look for the opportunities. So it's not that you've failed if it's not possible to do that. You haven't. You've only failed if you're not spending time thinking about that. And part of that might be asking the simple question of, when does the decision have to be made? And if the decision can be delayed, perhaps until the person recovers a little bit, well, then make the decision at that time. That's not always going to be possible, of course, but it's the question that you're thinking about. The second role, actually, I think I've got some slides to go through this. Yes, here we go. So thinking about what information and the environment. Sorry, I should have mentioned about the environment. Think about what environment this person needs, which type of setting is more conducive to that person receiving and understanding the information. The second kind of role is your representation. And of course, in non-instructed advocacy, you're going to be representing the person. And these are the questions that you really need to be looking out for. So the first one is, what would the person want if they could decide? Would they want this treatment? Would they want to have this surgery? Would they want to have this peg tube fitted? Would they want to have this dentist work? And of course, ideally, you'd be asking the person in order to represent them. But if you're not getting any clear feedback from your partner, then you need to be asking the views of other people around them. So if they have carers or neighbours or people who know that friends. Now, as I'm saying this, I'm acutely aware that people who have an IMCA, more than likely, they've been assessed as not having anyone who can act in the consultee role. That doesn't mean that they don't have anybody who know them. So it's worth talking to the to people who are around them to find out what their views are. You then might want to spend some time thinking about the lifestyle of the person and choices that are important to them, things that make them happy, and then consider what preferences or values might be relevant. If somebody is fiercely independent, then that might have a bearing on the decision. Where they are in their life is also going to have a big impact. But what we're thinking about here is, what's important to my partner, and which parts of that do I need to bring forward so that the decision maker knows what's important to them. And of course, you will write a report to represent, and I put here, your role is to influence the substituted decision making process. So if you think about the two roles of the advocate, you've got the supported decision-making role, where you are helping that person to make their own decisions. But then you're also feeding into the substituted decision-making process, by which we mean the state, in which case the doctor, is substituting the decision on this person's behalf because they've been assessed as lacking capacity to make it. And it's really important as part of that process that the person's views and wishes are heard and taken into account. Part of the representation, particularly in serious medical treatment, is about gathering information and doing some research. Now, there are lots of treatments where you can find out best practice guidelines. NICE, NICE, National Institute for Clinical Excellence, is a good source, as is the NHS, of course. And here you will be looking and researching, is this treatment best practice? What are the benefits and the burdens? I'm going to return to this idea. What are the risks? What happens if the person resists the treatment? What's the kind of prognosis after the treatment, or likely prognosis? This is where you're going to bring that just very human quality to your questions. If this was my loved one, what questions would I be asking? What would I want to know? And of course, your source for this information may well be the person who's the decision maker. It may well be the consultant or the doctor or the dentist. You may be interviewing them to get that information. And the last kind of circle in our advocacy role is the audit function, which is the check and challenge. So when we think about human rights, particularly in accessing health, there are certain things that we need to be mindful of. So there is a right, of course, to access treatment and not to be discriminated against. There are huge health inequalities in our population at the moment. Um, it's important to recognise that, particularly when the person lacks capacity. Many people with a disability are denied access to treatment because of the disability. This is really prevalent in people with a learning disability. So it's really, really crucial that you are mindful and checking the proposed decisions to withdraw or stop or limit treatment options and not influenced by this idea of, oh, well, the person who has a learning disability, therefore they don't have a quality of life, therefore we're not going to offer. And it just sounds absolutely awful to say those words in that order, but that is what happens. Particularly with decisions like DNA CPR, we've heard absolutely awful horror stories, haven't we, about people being denied access to life-saving treatment because of a learning disability and age. There's also something about using your legal rights, and as an IMCA, you have a legal right to ask for a SOAD. So SOAD stands for a second opinion approved doctor. In mental health settings, there is a legal right. In general NHS, I don't think there's a legal right to have a second opinion. However, it is fairly common practice, and most hospitals and within the NHS, it's very common practice if you're not certain to request a second opinion. So you can do that as the IMCA, and you should do that, particularly if things are unclear or if you think that the person wouldn't want what's being proposed. It's good to get a second opinion to see if there's any alternatives. Like all forms of advocacy, the challenge route starts, at the informal. So if you're concerned, you'd have a conversation with the decision maker, and you would continue to escalate that as appropriate. Complaints processes are there, but if you want to get a decision changed or made, I think a complaint process might take too long. So you might want to take it straight to the Court of Protection, in which case talk to the NHS body that's making the decision, and obviously get some legal advice. But you can take contentious decisions or just best interest decisions really to the Court of Protection if you feel that it's not in the person's best interest, or the person really strongly, or just not strongly, but the person wouldn't want what's being proposed. Okay. Oh, there's a slide here on second opinion. So you can seek a second medical opinion if there's uncertainty, find balance. If you're worried that it's not in the person's best interests, or if you're worried about proposed treatment or decisions not to treat, then that's when to get a second opinion. I think we've covered that now. Okay, so final kind of chunk of content here. So when you're writing your report, so you've gathered your information, you've been to see your partner a couple of times, you've spent time thinking about how do I help the person make decisions. You've got all your evidence together and you're sitting down now to write your report. So remember, we like simple, clear structure. The story is not about you. So you're not writing a story of what you did. You're not saying, I visited Peter, I visited Dwayne, that this is what we talked about. We're not doing that. We're writing an analytical report about your partner's views. Or if you can't find clearly what your partner's views are, their likely views. and how the proposed decision is likely to impact on your partner. That's the kind of the the most important part of this report. So I would start by saying, what's the decision? Always be very clear about what the decision being proposed is and why is it being made now. So what are the circumstances? So you told maybe a couple of sentences, a paragraph to just set the context, and then go in with what you found out. Part of that, of course, is putting forward what the views of other people are. That's likely to include some medical opinion, but it may include carers' opinions about the impact. And when we're looking at the views of others, remember there's two questions in IMCA, in non-instructed advocacy, that you can ask. The first question is, what do you think should happen? So Dwayne is, being considered for, open heart surgery. What do you think should happen? What's your view? That's a good question to ask. The second question to ask, which I think is a better question to ask, is what do you think Dwayne would want to happen? So the first question is, what do you think should happen? Second question, what do you think Dwayne would want to happen? And that's kind of how we gather in that rich information about the likely impact. And now in your report, and I want you to write this down because this is so critical in SMT decisions, you want to spend time identifying and exploring the benefits of the proposed treatment and the burdens of the proposed treatment. So this is your pros and cons, your do's and don'ts list. Yeah. What are the reasons to have the treatment and what are the reasons not to? And this is where you're kind of going to logically, rationally go through all the information that you found and present it to the decision maker. I've seen this done in table form, so it's kind of obvious which has more weight. I've seen it in prose style, which is really good if things are complex or nuanced. Then feel free to write about it and explore it. But what you really want to get to is clarity for the decision maker on what you found the potential benefits and the potential burdens to be. And then in any IMCA report, you're going to finish by summarising and asking questions that you want the decision maker to take into account, that you want them to consider as they make this decision. And these might be things like everybody agrees that it's in the person's best interest to go into hospital. But if the person's autistic, that might be very, very frightening for them. And in the past, they've become very distressed in hospitals. So in the points for consideration, you might be suggesting things like, is it possible that the person is first on the list? So they don't have 6 hours waiting in a hospital ward, getting all wound up and distressed. Or it might be appropriate for them to have a pre-med. Or it might be appropriate to really think hard about which staff accompany the person. So it's staff that they're known and trusted. It might be that you take objects of familiarity and reference and comfort in. There's been lots of just very sensible, we're going to take the person's duvet in. So there's a known sensation there rather than a hospital blanket. These small things can really make a difference of the success and efficacy of treatment. So be thinking about the broader points for consideration as well as the perhaps more obvious ones. Okay, I'll leave you in Helen's safe hands now. And like always, if you've got any questions, drop us an email. But I think we've covered everything there. All right, then take care, guys.